Good afternoon, everyone. For those who don't know me, I'm Ravi Poshraju. I'm one of the ICU consultants at the Leicester Royal Infirmary. Today's topic for afternoon teaching is on Guillain Barré syndrome. The reason I picked up this topic is that last year we had almost 4 patients, almost back to back, and for a very long period of time, we had at least one patient with Guillain Barré on the unit. And I felt it's probably more useful to do a bit of teaching on this, because once we get a patient with this particular diagnosis, they do stay in the ICU for a significantly long time when compared to many other reasons for ICU admission otherwise. Uh, and also for those who are giving I don't know any of you are giving anesthetic or maybe in the future ICM exams, Guillain Barré syndrome is a quite favorite topic for both the FRCA and the FICM as well. It's very useful to have a bit of revision on this. So by definition, Guillain Barré syndrome is an acute ascending inflammatory polyneuropathy, which is causing fairly symmetric paralysis, most commonly beginning in the lower limbs. So the characteristic features are it's acute in onset, usually begins with in the lower limbs, begins with probably paresthesia initially, and then they start to spread up. Patients usually complain of constricting ring-like pain in their ankles, in their elbows sometimes. Then the pain gradually, the paresthesias, they gradually ascend up, and sometimes along with the paresthesia, sometimes after the paresthesias, there is this onset of muscle weakness, which then starts to again ascend. It's usually mostly proximal muscle weakness. So the patients classically complain of, inability to get up from a chair or inability to climb stairs. So that's very classic of this particular syndrome. The incidence is fairly constant across most of Europe, America, and maybe large parts of Asia as well. It's about 1 to 2 cases per 100,000 people. And men are commonly affected more than women. And the incidence tends to increase with age. Possibility being probably they get exposed to maybe more vaccines or more infections as age goes by, or because of some other comorbidities which might trigger a GBS, but not clearly known. And also, the higher the age of the patient at presentation, the worse probably is the mortality. So there is some correlation between an advanced age and a worse outcome with this particular diagnosis. On its own, the diagnosis can be pretty straightforward. What are you looking for? You're looking for a classic weakness, which has a very sort of predictable mode of spread in a fairly majority group of patients. You're looking for lack of reflexes, areflexia, and you're trying to sort of corroborate with an antecedent history of possibly a diarrheal illness or an upper respiratory tract infection. So it's fairly easy to put all of these three together. We don't need sort of major investigations at this point. It's all mainly history based. And if you do get the history properly, it's fairly easy to diagnose or suspect diagnosis of Guillain-Barré syndrome. But what makes this more complicated is that the duration of illness is quite prolonged. And because of that, and because of what happens to these patients in that duration of illness, whether they are on the wards or very often 20 to 30%, they end up coming to intensive care because they need respiratory support. They do have lots of other complications added on in that course of illness, and that leads to a bit of unpredictability in outcome. I've also included a couple of case scenarios that we had here at the LRI ICU last year, and I've included 2, and both of them had sort of different outcomes so that we know what actually can happen with these patients. And outside the setting of trauma, Guillain-Barré syndrome is possibly the most common cause of acute onset flaccid paralysis. So etiology, 60% of the cases, there is always a sort of an antecedent, an upper respiratory tract infection, could be viral, usually viral, sometimes bacterial. And also a large proportion of these patients have an antecedent diarrheal illness. Campylobacter is said to be the most common culprit, which precedes these episodes of Guillain-Barré presentations. And at the heart of it is probably an aberrant immune response to the infection itself. So what possibly happens is that the body is trying to react in a way to the infection. And then there is probably a bit of molecular mimicry going on, wherein there is cross-reactivity between antigens on the infective agent, and possibly the similar type of subset of antigens are present, or similar antigens are present on the nerve membranes, on the axon sheaths. And as a result, the nerves start to get damaged. So there is that happening. That's probably one of the what looks like a plausible explanation of why these sort of diarrheal and upper respiratory tract illnesses can lead to this. And once the nerves start to get damaged, you do see a lot of complement activation, lots of infiltration with macrophages, lots of edema, which then cause not completely reversible damage to the nerves. The damage will take a long time to completely be reversed. Usually peripheral nervous system is affected, but then in at least 60 to 70% of patients, there is a very significant autonomic instability component. So there is involvement of both. The illness is very typically monophasic, which means that the patients present to the hospital with these types of symptoms, then they deteriorate, they reach their, the lowest sort of nadir of their illness in about 2 weeks. And then the patients sort of are treated in that 2 weeks if they are in the hospital. And then after that, they progressively start to recover. And that is fairly predictable for at least sort of 40 to 50% of these Guillain Barré patients. There are always patients who are outside this, wherein there could be some treatment-related fluctuations that can happen later on in the course of the illness. But the monophasic nature is very, very sort of characteristic. So there is an initial progressive phase for the first 2 weeks, and then there is a very long plateau phase wherein, from a Guillain Barré point of view, nothing happens. But then these patients are at that point in time in the ICU, most often, or in the hospital, and they get lots of hospital-acquired infections, ventilator-associated pneumonias, and lots of other complications which we'll see, which are associated with being sort of immobile. So the major antecedents are, as I said, upper respiratory tract infections, Campylobacter, but also there is a reasonably sort of high proportion of patients who have an antecedent CMV illness or EBV illness, also associated with HIV in quite a few patient populations. The infrequent ones are bacterial illnesses like H. influenzae or leptospira. There is also an association with prior trauma surgery, but then most of them are anecdotal with no basic, large trials corroborating that degree of evidence. What is questionable, though, is a link between the vaccines and Guillain Barré. Now, in the late 1970s, when there was swine influenza vaccines that were administered, there was an increase in the incidence of Guillain Barré syndrome at that point in time. But then time and again, lots of other evidence has shown that it's probably not that significant, and the benefit of actually giving the vaccine to susceptible population is a lot more than the theoretical risk of actually having Guillain Barré. And even now, when we go to get these flu and COVID vaccinations, there is always a warning that this could happen. But the benefit of the vaccines far outweigh the risks from Guillain Barré and vaccine administration. What is also very typically seen with Guillain Barré is the incidence, the increase in incidence during viral outbreaks. So it has been definitively seen when Zika virus outbreaks happened in about 2013, 2015, that time frame, and that's when the American Academy of Urology, they sort of put together a list of guidance so that people can actually use it to change their practice or modify their practice. Just looking through COVID, there is also some evidence coming from the US that there was actually a significant increase in Guillain Barré with COVID as well. So the incidence of Guillain Barré in outside of these viral outbreaks is about 1 to 2, as I said. Then there are a few studies from the US which say that the incidence actually went up to almost 10 to 15, which is a significant increase in any disease. So what are the diagnostic clinchers and when do you want to suspect Guillain-Barré? So ascending paralysis, that is definitely should be on top of your list. Although there is a small group of patients who can actually present with just upper limb weakness or facial weakness, but by far 80 to 90% they will have an ascending paralysis beginning in the lower limbs. There are lots of variants as well, which we will see going forward of this Guillain-Barré syndrome and Miller-Fisher variant, the Bickenstaff brainstem encephalitis variant. Some of them have a predominant pharyngeal, brachial distribution. Some of them are just sensory. There will be respiratory muscle weakness in around 20 to 30%, which usually is the reason for intervention and referral to ICU. Patients typically present of back pain along with lots of other paresthesias, and there is autonomic instability in, as I said, in 60 to 70%. So the clinical presentation is very typical and it's easy to diagnose and suspect from that point of view. From a neuro exam, so classically these patients will have bilateral weakness, which is fairly symmetrical. Reflexes are usually absent. And though they present with paresthesias, the sensory exam is usually intact in these patients. So they don't have a sharp sensory level when you start to do a detailed neuro exam in these patients. From a lab and electrophysiology point of view, classic, as we all know, is the albuminocytological dissociation that is seen when you sort of send the CSF analysis, which means that there is a rise in protein count with a normal white cell count. Having said that, it's actually not needed to really diagnose, because the diagnosis should basically be clinical and you should not be wasting time before administering useful treatment because you're waiting the LP results. The reason for that is it takes for about a week for this albuminocytological dissociation to actually appear on the CSF analysis. And the patients might actually present even before that. And very often some of them, they have severe sort of progression of weakness and they end up from coming to the hospital and coming to the ICU, getting intubated, ventilated, all within 48 to 72 hours. So there's no point. We should be doing the LP and sending the CSF. But again, the main reason for doing that is to rule out lots of other differential diagnoses which can, have similar sort of some of the features can be present in lots of other, metabolic or toxic neuropathies. Likewise, ENMG in the acute phase, it's a complete waste of time. Even if you ask the neurology, they're not going to do that. So even if the patient is in ICU, they're not going to come and do an EMG study in the first sort of 1 to 2 weeks. Typically, it is more useful and you get characteristic findings on the EMG maybe after about 2 weeks. Is it useful after 2 weeks? Well, from a neurologist point of view, what it can say is whether this patient has got an acute inflammatory demyelinating polyradicular neuropathy, which is the most common variant, or the patient has axonal neuropathies like motor or sensory, or a combination of motor and sensory. And from a neurology point of view, what it can sort of tell them is, if it's axonal, possibly this patient is going to have a long period need a long period of mechanical ventilator support if they've developed respiratory failure. If it is a very atypical AIDP variant, then it can suggest to them that this patient might actually still need a lot of ventilator support in long duration, but possibly there is a subset of atypical patients with AIDP presentation in whom the outcome, even after long ventilator support, is pretty poor. So in the acute phase, it's probably not going to benefit us, which is probably the reason why they're not really inclined to do that. And what do you find if you do it? You find reduced action potentials, reduced conduction velocities. And what they typically do is they test at least 2 motor nerves, usually median and ulnar. And what is typical from an ENMG point of view is sural sparing. The sural nerve is spared of the Guillain-Barré syndrome. And then, as I said, most of these patients, they are at their sort of worst sort of clinical picture at about sort of 3 to 4 weeks from onset. And just sort of brief mention about what happens with neuromuscular, physiology in respiratory physiology, neuromuscular disorders. So normal sort of breathing, inspiration and expiration, the diaphragm tends to go up, the chest expands outwards, the abdomen sort of expands outwards. You just breathe in and breathe out. That's fairly common. If there is evidence of any sort of neuromuscular weakness affecting respiratory muscles and diaphragm, there is a bit of paradox. The diaphragm doesn't go down, it actually goes up. The abdomen goes in and then the chest goes out. There is a bit of paradox in the way that these patients breathe, which effectively means that they are not ventilating properly because of these thoracoabdominal paradox. And associated with that, there is also progressively decreased and diminished vital capacity, which will initially lead to sort of diminution of sigh, and then later on it will lead to a bit of hypoventilation, atelectasis, and then eventually it will lead to hypoxia, hypercarbia. Patients typically have staccato speech, so they speak in very short sentences, 2 to 3 words at a time. They can't do more than that. Significant accessory respiratory muscle use when you see them end of bed. There is an abdominal paradox, as I said, and there is a bit of diaphoresis and sweating because of the autonomic element of all of this. So probably end of bedogram of these patients is quite vital when you're seeing these patients either in your acute medical wards or in ED to actually, expedite the diagnosis and get some intervention early on. And also, from a physiology point of view, the normal vital capacity is about 65 mils per kg, and we should start to get worried when it starts to drop to 30, 25 in that range, which is why once you suspect Guillain-Barré, the nurses will be sort of, or the doctor team, they will be doing these vital capacity measurements in the on the wards whilst they are sort of waiting to come to ICU. So as I was saying, there's a lot of variation in the way that this syndrome presents, and this is probably more useful than what the ENMG variants are, which is the Amon variant, the Asman variant. That's probably of less interest to us as intensivists. This is probably more useful, and about 84%, 85% they have this classic AIDP mixed motor sensory picture. And which is again fairly uniform across most of Europe and America, and probably 30 to 40% of patient presentations in Asia are also of same type. And then you've got lots of other types wherein it's pure motor, it is pure sensory, or it involves just the pharyngeal and facial muscles. And then there is the Miller-Fisher variant, which is characterized by ataxia, erythroplexia, and ophthalmoplegia. And then there's Bickenstaff encephalitis, which is characterized by a lot of these, which are there in the Miller-Fisher variant, but also with altered sensorium. What is probably useful to remember when you are trying to figure out what actually is happening with this patient and what is the predominant involvement is that there is a significant overlap between these variants. So you might not get the classic sensory motor always. You might get a patient who has what looks like probably a predominant Miller-Fisher variant symptoms, but also has a bit of sensory and motor. So there is a fair degree of overlap, but then that should not, alter your treatment management for these patients. The pure Miller-Fisher variant is actually not that common. It usually overlaps a lot with the classic variant. What's happened now? Okay. When do you have to doubt the diagnosis of Guillain-Barré? Obviously, the biggest red flag is if the patient deteriorates in the first 24 hours to the point of needing, ventilator support. That is a big red flag. I'm missing something major here because it's probably not Guillain-Barré. It's not going to happen that quickly in Guillain-Barré that they reach at the bottom of their clinical symptoms in that short a period. So if there is fever at onset, or if there is asymmetry in weakness, all of these should make you doubt the diagnosis on whether you should actually chase something alternative. Or if you've done a CSF and it's come out with a bit of lymphocytes or polymorphonuclear picture, again, that should make you doubt the diagnosis. And lots of investigations that we do, as I said, for Guillain-Barré are there to actually rule out the differentials and not to actually conclusively diagnose Guillain-Barré itself, because this is fairly clinical. But yeah, if the patient is progressing very rapidly to respiratory weakness, but doesn't have any motor or sensory symptoms, you should really doubt something else in that patient subset. So there's a big differential, but probably what is worthwhile to remember is obviously things like HIV, metabolic, nutritional neuropathies like vitamin B, B12, B6, thiamine deficiencies. Obviously, other neuromuscular disorders like myasthenia and Lambert-Eaton are probably should be there quite high up in the differential, because the treatment will then alter. And the other things that you probably need to rule out is any pathology in the CNS or in the spine, which is why these patients very often end up having MRIs, because you don't want to miss anything in the spine in these patients just because you're suspecting Guillain-Barré. So almost all of these patients will have imaging, mostly with an MRI, and if that's not possible, definitely a CT to rule out other causes. Treatment aspects, essentially, from an ICU point of view, they're here because they can't breathe. So we have to manage the ventilatory failure. They can also be admitted to ICU because they are having significant hemodynamic autonomic instability. So that, is important. And then obviously you have to give treatment modalities like IVIG, which can be given on the ward, but plasmapheresis is probably better off doing it in an intensive care setting. But aside that, all of the other aspects are probably much, much more important, because these patients are here for a very long time. I mean, the case scenarios that I have included are they've been here for about sort of 2 months or so, but in my memory, I did see a patient who was there for about 6 months and actually did not make any improvement. And then at some point in that journey, they'll get referred to long-term ventilation units. So a lot of other things like meticulous nursing care, psychological support, physiotherapy, occupational therapy, rehab planning, nutritional support. These are probably the most important, maybe after the initial 1 week, when you've actually sorted out the first three, because you would have intubated the patient, you would have put the patient on ventilator. IVIG is a given because we would give it, we will not waste time. And then you will monitor the patient anyway with invasive monitoring to look for any autonomic instability. But then where we need to persevere and do it meticulously is the other bits like the nursing care and PT, OT. Those bits are very, very important in these, which can affect the outcome in these patients. So when would you want to admit the patients to intensive care? Obviously, they are in respiratory distress. That's a no-brainer. Rapidly progressing weakness, autonomic instability, again a no-brainer. You would want them to be in here. Even if you're not worried about the patient straight away that they're going to be intubated, it's probably a good idea to actually either let the outreach team to keep a close eye, or if there is more than normal concern, get them to intensive care and monitor them, because they can actually get lost if they are in a ward and they're not being looked after, and the deterioration can sometimes be quite rapid. Obviously, if they've got bulbar weakness, again, that is a big, big indication to come to intensive care pretty soon. And at the bedside, what you can do is a single breath count. So after one inspiration without breathing out, ask them to breathe up to sort of count up to 20. And if they can't do 15, then yes, they are probably going to get intubated pretty soon. And then there is the FVC measurements that the nurses usually do. So what's the problem with FVC measurements in these patients? Suppose if you're referred saying that the FVC is like 0.6 or 0.7, and you're really worried about the patient, and medical registrar refers. It is subjective, but why is it subjective? Yeah. Why could that be? Mouth seal. Yeah. So there could be an issue with mouth seal. So they could be having facial weakness, and that could actually impact the seal. And again, there could be a subjective element in terms of whether they actually know how to do this or not. So again, an endobeddogram is probably more important rather than relying on just one measure. What about blood gas? Would you ask for a blood gas? Because as ICU doctors, we ask for a blood gas every time. What about a blood gas? How many of you would want to ask for a blood gas? You would want a blood gas? You would? Yeah. 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 But would you definitely want a blood gas before you call intensive care? Well, it depends on the patient. Yeah. So, I mean, if you've done a blood gas, an arterial blood gas, which already shows hypoxia and hypercapnia, I think we have missed the boat already. And the patient is actually, if that is the time when you've actually spotted the severity of the situation, that patient is actually at significant risk of, imminent deterioration. So, angiogram and the other bits are probably more important rather than relying on a blood gas, because it could be quite late before any changes are evident, because the vital capacity has to drop to very low levels for the blood gas to show hypoxia or hypercapnia, because that's what you want to see in the blood gas. And in the initial phase, when the vital capacity is starting to drop, the patients might try to compensate. So there could be a period wherein it just could be, hyperventilating, and the PCO2 could be a bit low, but that should not sort of lead you into a sense of safety. So probably relying on blood gas is only on blood gas is probably not a very safe thing to do when you're considering escalation for these patients. You have to look at the bigger picture. And very often this 20, 30, 40 rule is quoted, which is vital capacity less than 20 mils per kg, maximum inspiratory pressure less than 30 or less negative than 30, and then maximum expiratory pressure less than 40. But as you said, all of these are quite subjective, and they might not be very useful at bedside if you want to, if you're at the end of the bed of this patient in one of the medical wards, you might not get a lot of help all the time by getting to do these tests. So obviously the elephant in the room is mechanical ventilation, because that's the reason these patients very often end up coming to ICU. And very often the median sort of duration of ventilation in these patients with Guillain Barré is about sort of around 4 weeks for a general ICU. If you go into sort of long-term respiratory units, it's much longer than that. So very often these patients get intubated, ventilated very quickly, usually on day 1, on day 2 of ICU admission, because you don't see the patient progressing, and they are also at risk of many times bulbar palsy and weakness. So they get intubated very quickly. And at least in this unit and in many other units, the practice is to do a fairly early tracheostomy, because you want to move these patients forward. You don't want to waste a lot of time leaving them with an endotracheal tube in situ. So in here, we usually do a tracheostomy almost the next day or at least in that week, whenever time permits, and we wouldn't delay tracheostomy. And also, there will be a subset of patients who actually will look promising, that they possibly will end up getting extubated. But very often, the chances of even those patients needing a tracheostomy is pretty high. So this, I've picked up some data from Lane Fox Center, which is associated with the long-term respiratory unit, which is associated with Guy's and St. Thomas's in London. And obviously, they see a lot of patients with chronic respiratory failure. So they've actually presented this their sort of literature, and they've looked at, in a 10-year period, they've looked at about 29 patients with Guillain Barré syndrome that were referred to them from various general ICUs across the region and the country. And out of the 29 patients with severe GBS, their data suggests that 22 actually ended up being weaned off the ventilation. But there is a catch. The median time to liberation from mechanical ventilation in this patient subgroup with severe GBS was 193 days. So that is a lot of time. 7 patients they could not wean, and out of the 22 patients that actually managed to get weaned off from the ventilation, they had good functional outcome, in about 45%. So 10 to 11 of those patients actually regained, reasonable sort of independent ambulation or walking with assistance. So 45% of their cohort of patients in that 29, even though it's a long-term respiratory unit, despite prolonged periods on various weaning strategies, 45% did have a good outcome. So it's very easy to sort of get into a self-fulfilling prophecy because these patients don't move. As days goes by, they end up getting moved towards the high dependency area of the unit. There's not a lot happening with these patients, and we end up sort of doing the same thing. We say, okay, respiratory wean, ask the physio, tracheal mask, CPAP, and at some point it will appear that these patients are almost static. But at that point, you have to sort of look at the bigger picture in terms of what you can do to these patients, and whether there is something like if we are based in the general intensive care unit, should we be referring to these patients to some long-term ventilatory facility? Is probably something that you should definitely think and chase it up a bit and see if we can alter the outcome. And in the patients that they could not wean from ventilation in that sort of cohort of 29, a few of them had ICU-related complications like sepsis, DVTs, PEs. One of them had vocal cord palsy, so they could not, decannulate. And a few of them had very atypical presentations. So they had, not the classic sensory motor AIDP type of picture. So those are the patients who, in their analysis, the AIDP patients with atypical presentations, those are the ones who had the worst outcomes. The axonal neuropathy patients did receive a very prolonged duration of mechanical ventilation, but they could actually wean the patients then off completely from ventilation. So coming to treatment strategies, there's only two that you can do for these patients. Either you give immunoglobulins or you give plasmapheresis. The doses, again, are fairly standard. For immunoglobulins, it's 0.4 grams per kg, and then you give it over 5 days. Plasma exchange, you do 200 to 250 mils of exchange of plasma for every cycle, per kg body weight in every cycle, and then you do 5 sessions. You could use either FFP or albumin. Not sure what the practice here is. Is it albumin or FFP here? Okay. Yeah. So you could use either, but obviously the risk of complications are slightly more if you're using FFP, given the nature of the product. But a lot of work has gone in and research published on which of these is better. Both of them are equally efficacious, and there's no real indication to actually combine both right at the onset. What you should do is choose one of them, whatever your logistic facilities allow, and then wait for some improvement before you actually jump and want to sort of repeat the treatment. And I think the neurologists here usually advise to wait at least for about 4 weeks before they start to worry about, repeating the IVIG or choosing to do an alternative flex modality. And again, the timing is important. You have to do this quickly. So if you're planning to give IVIG, you have to give it really quickly. And if you wait for more than, if the patients are missed and if it is more than 2 weeks since the symptom onset, the efficacy is probably not great. And it's about a similar time frame for plasma exchange is about 4 weeks. You have to keep in mind side effects with IVIG as well. We usually start it as a very low dose infusion and then gradually necessarily monitoring these patients. Given the nature of products, there is a risk of anaphylaxis, but then there are other problems as well, like renal impairment and heart failure, which can happen. With plasma exchange, you don't get all the other side effects, but then plasma exchange needs a VAS cap. There are lots of line-related complications, and then given the nature of the procedure itself, it is associated with hypotension, given that you are exchanging. So if someone has autonomic instability, and if you have to choose between the two, probably IVIG should be your bet. And about 40% of the patients actually do not show any improvement even by week 4. But that doesn't mean that they have not responded. What it means is that if you have not actually done anything for these patients, they would be in a far worse situation than what they are at 4 weeks with the treatment. And in a small subset of patients, about sort of 5 to 10% of patients, there is what we call as treatment-related fluctuations, wherein the patients show improvement, and then after about 8 weeks, they again started to sort of show progression of the disease. And that time frame is important because that's what will sort of lead you to making a decision in terms of whether you want to give IVIG again or flex the patient again. Between the two, whichever you choose, if you think that this patient has had a treatment-related fluctuation, which I think has happened in both the patients that have included in this presentation, you have to give full dose. There's no point in sort of giving it halfway. You have to give the full dose of IVIG or all five cycles of flex. And what basically it suggests is that the treatment that you wanted to achieve with IVIG or flex is probably as worn off, but the ongoing inflammation and pathophysiological changes around the nerves are still continuing. Complications, by far, hospital-acquired infections, they are the main cause for mortality and morbidity in these patients. These patients die from them: sepsis, pneumonias, ventilator-associated pneumonias, DVTs, TEs. These are the biggest contributors to mortality in these patients. Aside that, you also have lots of functional psychological issues like delirium, depression, low mood, which again, though they're all sort of quite mental faculties, they will tend to affect your physical well-being and outcome. So it's important, therefore, to have a good MDT approach to these patients. So, which is why outcome prediction is probably crucial. And when these patients end up staying in ICU, you do have a lot of family conversations in that sort of time frame. And repeatedly, you are asked the same question: is the patient going to recover? How long the patient is going to go on the ventilator? Can the patient actually walk at any point in time? Or, some of them actually ask, can they actually go back to their functional baseline or not? And maybe for this particular disease, it's probably useful to have some numbers in mind before you, have these discussions with the family. So across most studies, about 80% of the patients actually make a good recovery, regardless of how severe the illness is. And even in the cohort from Lane Fox, they have shown 76% patients actually got weaned off. So 80% of the patients generally would actually regain the ability to walk at about 6 months. About 20 to 25% will end up coming to ICU, and almost universally they will end up getting ventilated. And as I said before, the median duration of ventilation is about 4 weeks. The mortality, again, that's fairly standard. It's about sort of 5 to 10% in this subset. And about 2 to 5% of patients, again, they have the risk of recurrent GBS for the same patient happening again is about 2 to 5%. And again, that's actually pretty high compared to, a lifetime risk of someone just being unlucky and having GBS. But there is a very protracted period of clinical recovery, which can sort of stretch to about 12 to 18 months in the first instance. And recovery can actually continue to happen even up to 5 years period. So you have to, with that numbers in mind, when you are looking after these patients in the sort of acute and beyond the acute phase in the ICU, you need to sort of make some rehab planning. So you need to involve physiotherapy and occupational therapy people so that they can actually work on these patients. They can have sort of a timeline for doing some graded exercise, passive mobility. Clinical psychology input is useful because mood of these patients is quite a big factor in how it affects the outcome. And one of the very annoying things that happens to these patients is their sense of fatigue once they actually recover from their respiratory insufficiency. And that actually can last for a very, very long time. And they probably will need a lot of physiotherapy support in that time to actually believe that they've actually built up some muscle strength. Pain is actually there even in the acute phase, and it can be muscular, it can be radicular, it can be neuropathic. We here usually give most of these patients gabapentin. We also give them clonidine. So it might seem very counterintuitive that the patient is actually not that awake, but underneath them being not conscious enough, they are pretty lucid. So they might still be in a lot of pain, which is why it's important that before you make a decision to stopping gabapentin, because you're worried that it's affecting the sensorium, what you need to think is that is the patient, do you think this patient is in a pain? And is it just the gabapentin that is clouding the sensorium is something which we have to ask ourselves. Okay. So just to summarize, it's basically a clinical diagnosis which makes you suspect GBS. All of the other lab investigations are fairly there to rule out all the other differentials. Respiratory weakness and inability to sort of do a single breath count to less than sort of 20 should actually be a big red flag for admitting these patients to ICU. We should not wait for LP or ENMG results before we start any treatment because time is critical. And whilst they are in the ICU, you have to monitor them for various other complications. Suppose the patients have autonomic instability and they have bradycardias. It might be that the patient needs pacemaker, and it has happened, and it is not uncommon thing to be done to these patients. You have to keep an eye out for early complications, which is basically infections, DVTs, and PEs. And sepsis from hospital-acquired infections and PE are the biggest sort of cause of death in these patients. And again, predicting outcome is important, but then, as I said, we should avoid the self-fulfilling prophecy that these patients are probably not going to get better, because they do. And there's lots of importance of rehab planning right from the start, which makes a difference in outcome. Okay, that's it.
I'm going to do the general club. So I'm Lakmal Jabba. I'm one of the specialty doctors. I'm currently working in Glenfield Hospital. So I'm going to discuss about a journal article that was published in JAMA in 2020 for June, which has been discussed in multiple critical care forums during last year. It's called BLING-III trial. So clinical question was, in critically lethal patients with presumed sepsis, does administration of beta-lactam antibiotics via a continuous infusion compared to an intermittent infusion reduces 90-day mortality? So a bit of background. So sepsis is the #1 killer in most of the intensive care units worldwide, and treatment with antibiotics is one of the mainstreams of treatment in line with source control and organ support. And beta-lactam antibiotics has been the antibiotic that has been used most to treat severe sepsis. So interestingly, beta-lactam antibiotics have a time-dependent bactericidal activity, and it's hypothesized that the improved antibiotic exposure with continuous infusions will lead to longer time above minimum inhibitory concentrations with potential improved bacterial eradication. And in addition to this, especially in sepsis patients, there will be a possibility of underdosing due to increased cardiac output, leading to potentially increased duct clearance due to supranormal. Possibility of underdosing, especially in the septic patients, because of supranormal cardiac outputs, and then increased clearance due to supranormal GFR and increased volume of distribution due to capillary leak. Plus, there was multiple studies in recent past comparing this continuous versus intermittent antibiotic infusion in sepsis. Especially this BLING-III is a series. They had BLING-1, BLING-II studies, and the MERCY study, which was done in 2023, which gained a lot of attention. All of them looked at the continuous versus intermittent antibiotics. None of them have revealed a significant mortality benefit, but all of them have shown non-significant absolute difference in mortality in favor of continuous infusions. So this was a study that is sort of designed to answer questions in a sort of grand scale. So it is a multi-centered, multinational randomized controlled trial. It involved 104 intensive care units in 7 countries: Australia, New Zealand, and 55 intensive care units from UK, Belgium, France, and so on. So recruitment started in March 2018 and finished in January 2023. And they have used a randomization one-to-one via an online algorithm. So open label study, both the clinicians and the treated patients were aware which arm of the study they were in. The sample size of 7,000 was required to achieve 90% power and to detect a 3.5% difference in all-cause mortality at 90 days, including 5% loss to follow-up. And we have done pre-specified adjusted analysis accounting for sex, aperture score, source of admission, and type of antibiotics before randomization. And there were 5 subgroups, including whether the patient had pulmonary infection or not, what beta-lactam antibiotics was used, whether they were more than or less than 65 years in age, male or female, or Apache score less or more than 25. And they have looked at a secondary outcome, which is clinical cure, which was defined as completion of beta-lactam antibiotics by day 14 without recommencement of antibiotics within 48 hours for the same infective episode. But this was decided by the treating clinician who was aware of the initial treatment protocol, not depending on sort of pre-specified clinical parameters like temperature, inflammatory markers, or new requirement of organ support. We'll have to go back and share once again because slides are not moving. Sorry about this. So inclusion criteria for this study was patient has a documented site of infection or strong suspicion of infection, and patient expected to be in ITU for more than 2 days, and patient has been started on tazocine or meropenem for the suspected infection, and either tazocine and meropenem as infusion or intermittent boluses has been considered appropriate for the patient, and patient had 1 or more organ dysfunction criteria in the previous 24 hours.
Your slides are moving now, so don't go back.
Okay. So exclusion criteria has been patients less than 18 years, patient received tazocine or meropenem for more than 24 hours during the current infectious period, pregnant patients, patients known to be allergic to the given antibiotics, and patients currently on renal replacement therapy, and the treating physician thinks that advanced life support is not suitable for this patient, and the death seems imminent in the near future, or the patient has been enrolled in BLING-III study previously. So in the intervention group, the patient received continuous infusion of beta-lactam antibiotics over 24 hours. The median duration of antibiotics was 5.8 days in the continuous infusion group, and they have received a median tazocine dose of 72 grams or meropenem of 17 grams. The control arm, intermittent infusion was given over 30 minutes, median duration of 5.7 days, which is almost similar to the intervention group, and the cumulative doses were again mostly similar to the continuous infusion group, that is 72 versus 70 grams in the
your slide is stuck at exclusion criteria.
Yeah. Is it moving?
No.
Okay, I go back to sharing.
It's come.
Can you see?
It's come to intervention and control now. Can you go on to the next slide?
Yeah.
Don't share it. Just press tab.
Okay. Is it moving now?
Yes. Yes.
Okay. So 29,042 patients has been screened, and 7,202 patients were randomized for the study, and 22,000 patients has been rejected. And almost half and half of the randomized patients were selected for continuous and intermittent antibiotics. And comparing the baseline characteristics in the two groups, they have been very much similar. So to look at this, the demographic characteristics like age, sex, weight, height, then other parameters like source of ICU admission, the Apache score, and then the organ dysfunction parameters like PF ratio, the lowest value, highest creatinine, highest bilirubin, lowest platelet count, and then the primary site of infection, all have been as baseline characteristics has been more or less same in both groups. So outcome-wise, the primary outcome they have looked at is the all-cause 90-day mortality, and there was no significant difference in this. So in the continuous group, the mortality has been 24.9%, and the intermittent group, it was 26.8%, with absolute difference of 1.9 reduction in mortality with the continuous infusion group, with the confidence interval of -4.9 to 1.1, with a p-value of 0.08, which just missed the magical significant level of 0.05. Then they have done, as I mentioned previously, they have done a pre-specified adjusted analysis of absolute, which result in absolute difference of 2.2 in favor of reduction in mortality in the continuous group. So in this, what they have considered is they have considered the difference in baseline characteristics of the patients and use that data to do the adjusted analysis. So this result in a clinically significant difference with a p-value of 0.04. But because the research group have decided on using the raw data initially, they have not considered this adjusted analysis for their primary outcome. But I think the most of the statisticians believe that the primary outcome should be based on the adjusted analysis that corrects the corrects for the baseline differences in the group. Secondary outcomes, there was significantly greater clinical cure rate in the continuous infusion group, which was 55.7 versus 50% cure rate in the intermittent bolus group, with absolute difference of 5.7 and a p-value of less than 0.001. But there was some concerns over this, which I'm going to discuss later. And the other secondary outcomes, there were no significant differences in both groups. They were the new acquisition of colonization of infection with methicillin-resistant organisms, so Clostridium difficile, all-cause ICU mortality, all-cause hospital mortality. And if you look at the absolute differences, all of them are in favor of the continuous infusion group. There was less number of new acquisition of these organisms, less ICU mortality, less in-hospital mortality in the continuous arm. And the tertiary outcomes they have looked at is ICU length of stay, hospital length of stay, duration of mechanical ventilation, and duration of renal replacement therapy. None of them showed a clinically significant difference, but again, all of them are in the favor of the continuous infusion group. So this, they have done, as I mentioned, there was a pre-specified 5 subcategories, and they have shows the mortality in all the 5 groups. So whether the patient has a pulmonary infection or not, whether the patient had tazocine or meropenem less than 65, more than 65, male or female, or Apache scores less than or more than 25, all of them in the continuous group has less mortality. It can be seen in the fluorescence plot to the right. Again, p-values were more than 0.005, but all of them show promise towards non-clinically significant promise towards the continuous infusion. So adverse effects have been very minimal, only 0.3% in the continuous group, 0.2% in the intermittent group. But this was not related to the mode of drug delivery, but to the use of antibiotics in general, that is very similar to baseline population. So talking about strengths of this study, it was an extremely large randomized controlled trial with robust internal and external validation, 7 countries, more than 100 ITUs, and more than 7,000 patients. And there was a detailed screening log with a majority of these screened but not enrolled meeting exclusion criteria. Very balanced baseline characteristics. Dose and duration of antibiotics has been similar in both the groups. There was detailed collection of infection site and antimicrobial data, and there was minimal loss to follow-up, and even they have accounted for this follow-up when they decide on the number of cases they are going to study. Weaknesses, main weakness that was pointed out was this was an open study, so it's an unblinded study for the treating physicians, and the patients knew which arm they were in. I was listening to some podcast done by the main investigators, and this was unblinded because the sheer extent of the study, and it was very labor intensive, and it's going to be very financially intensive if they are going to make it a blinded study using a placebo drug, which was not possible with the grant they have received as well. The other thing was the dosing has been reverted to intermittent dosing when the patient is discharged from ITU and the patient was still on antibiotics, and they have been on intermittent antibiotics before admitting to ITU before randomization. And there was no consensus about the definition of clinical cure. That was the only clinical significant difference in the 2 groups. While the definition used in this trial was pragmatic and objective, there was a question whether the 48 hours long enough following session of antimicrobials to say there was clinical cure. And because the study was unblinded, the clinician knew that which arm the patient was in, and the same clinician decided whether he's going to start on antibiotics for this patient or not. So there was an element of bias in that as well. And there was a potential that patients with non-infectious causes of organ dysfunction are included in the study. And again, it's pointed that most of these studies done on sepsis had less than 50% microbiology proven studies overall. And to achieve the power of this study, it's very difficult to only include patients who had microbiological diagnosis of sepsis, and it was only about 20% in this study. And there was lack of reporting on therapeutic dose monitoring or antibiotic sensitivity. And approximately 1/3 of patients had a protocol violation, but this is mainly in the form of delay in starting antibiotics by more than 1 hour, so it's not a major problem. So in conclusion, they have concluded that the observed difference in all-cause 90-day mortality between continuous versus intermittent infusion of beta-lactam antibiotics did not meet statistical significance in primary analysis. So there's some concerns about this 90-day mortality as well, because sepsis is something quite acute. So from the ICU follow-up studies, there was a lot of evidence that up to about 2 years, patients who had severe sepsis has excess mortality compared to baseline population due to the endothelial dysfunction, myocardial dysfunction. There was sort of deaths due to myocardial infarction, cerebrovascular accident. So whether it was prudent to have mortality for shorter duration of time. So what, even though there was no clinical significant difference, there was a lot of promising outcomes in the form of the absolute difference was 1.9, which means every 40 patients that has been treated, there will be an additional death that is prevented by using continuous antibiotics. And there was clinical significant difference in clinical cure of the in the continuous arm, plus all subgroup analysis and secondary and tertiary outcomes showed promise towards the continuous infusion. So what the study group has done is they have done a meta-analysis comparing 17 very recent studies on prolonged versus intermittent infusions of beta-lactam antibiotics. So out of these 17 studies, 10 of which contribute to 95% of data, was very low, had very low risk of bias, and which concluded that there was 99% 1% probability that prolonged continuous infusion of beta-lactam antibiotics is going to reduce mortality. So I'm going to critical appraisal of this article, which I'm going to use CASP tool, that is Critical Appraisal Skills Program, to do that. So the first question is, did the study address clearly formulated research question? Was the study designed to assess the outcome of an intervention? Yes, it was continuous versus intermittent antibiotics. Is the research question formulated in terms of population studies? Yes, it was on severely septic patients who were admitted to ITU. Intervention was, as I mentioned, intermittent versus continuous antibiotics. And outcome measured, there was primary, secondary, and tertiary outcomes that was clearly stated with subgroup analysis as well. Was the assigned participants to investigation randomized? Yes, it was a web-based one-to-one randomization. Were all participants who entered the study accounted for its conclusion? Most of the patients were included. They have even accounted for 5% loss to follow-up, but the loss to follow-up was less than 1% in this study. Were the participants blinded to the intervention? So because it is an open study, participants were not blinded, and then the investigators were not blinded, and the assessors were not blind, and that was a shortcoming in this study, which was a sort of very practical, difficult procedure I have discussed previously. The other thing was, apart from the experimental intervention, did each group receive same level of care? Again, it was a yes. Other than the mode of administration of antibiotics, the rest of the care for sepsis is according to standard protocol to the unit. Were the effects of the intervention reported comprehensively? Again, the power calculation was undertaken before starting the study. Primary, secondary, and tertiary outcomes have been clearly specified and measured. There was minimal missing or incomplete data. They have identified potential source of bias and appreciated that, and the p-values has been compared. Then the other thing is, was the precision of the estimate of the intervention of treatment effect report, that is about the confidence intervals. They have mentioned the confidence intervals in each group very clearly. Next thing is, do the benefits of experimental intervention outweigh the harms and cost? So as shown in one slide, the side effects of the antibiotics has been minimal, and it has nothing to do with the mode of administration, which is the study they have done, but its usual side effects of antibiotics in the baseline population. And about the cost, there was no additional cost because the antibiotic doses in the intermittent and continuous arm has been the same. So the cost has been the same in both groups, and the other thing is, can the result be applied to your local population? It's yes, again, because 55 out of 107 ICUs has been in United Kingdom, and most of the other countries the study was done, the healthcare system and population are more or less similar to the population here. And finally, would the experimental intervention provided greater value to the people in your care than any other existing intervention? So what we currently use is intermittent infusions, but from the data available, we can't sort of give a solid answer whether it is yes, no, or can't tell, but I would rather say yes or can't tell, because there was a lot of positive trends from the study. So I think that concludes my journal club. So I think just one more thing I just wanted to highlight, because listening to the chief investigators of this study, they mentioned this in the current era where the medical, especially critical care is so much improved. It's very hard to get a statistically significant clinical difference from one intervention. It's going to be multiple interventions, doing small things and adding together in totality, which is going to make a difference. So it's up to the treating clinicians to decide whether this is something that they can look at in their own patients to improve outcome. And there was something highlighted that whether the continuous infusions will help in sort of subgroup of patients, like severely ill patients, the patients who are infected with organisms that have high MICs, whether this subgroup of patients will benefit from continuous infusions compared to other groups. That's something to think about and something to do studies in the time to come. And with that, I conclude my presentation. And if there's any questions, I'm happy to answer if I can.
Thanks, Lakmal. That's useful. So, I mean, I'm not sure how difficult or easy it is to do on a basis. Access for a continuous infusion.
Well, access is probably your one limited factor.
Yeah.
If you've got quad lines, if someone's sick, or if you
Yeah.
have a CPC with a quad line, you shouldn't bring you to town. Lots of units have done this, but that's done good care. If the evidence isn't strong as you think it should be,
But it looks like there is a marginal benefit from.
there's a signal.
Yeah.
There's no statistical difference. In the meta-analysis, although they present it as information on this work, with lots of holes and you look into the analysis for different antimicrobials, different lengths of fields. They're not all consistent trials that match the same thing. But there is a signal of benefit. And the small thing is no signal.
Yeah.
So I don't think you're going to harm a patient by giving them a signal.
Yeah.
And you potentially may benefit. But one of the biggest, risks or issues with this trial is exclusion criteria of patients on RRT. They're probably the cohort of patients where you potentially have the most benefit of infusion.
Yeah.
And our sickest patients routinely
are, yeah.
So there's a couple of patients here with no idea what benefit is.
Yeah.
They seem to be much stronger in those patients. You look at as well, they will see excluded from all trials. We also be in the cohort of patients where you have a lot of benefit. So, you don't know if it's going to work in the majority of patients. There will be some patients where potentially might improve mortality. So unless you use it as a blanket therapy in everybody, capture those patients, a little more judgment, and it's very difficult to select the patients to do it, which is why kind of hospital centre care is accepted patients. One of the most things type in the adoptive policy is how you can transition care into ICU out of ICU. So you can start patient, patient board, they can be intermittents. Discharge the patient on manual as you need to convert that back to dosing. Towards one have the capability to get infusions. Here, well, sometimes we do have access issues if the patients are not being able to start develop sepsis during that ICU stay. Got rid of their sepsis. So that would be an additional challenge. Wishing that we don't patients access issues again.
Yeah.
It was about nursing care. What's easier for
This is much easier.
Yeah, and there's enough stability days now. You can either do 24-hour infusion, or if you're a bit more cautious, you do 3 8-hour infusions. Again, it's supposed to be easier.
Okay.
Oh, probably.
Yes.
Yeah.
Yeah. Not when you go online.
Yeah.
It's pretty sort of one.
So if we do prepare an infusion which is going to last 24 hours, is the drug going to be stable for that entire day? Okay. So that's the other thing.
Yeah. So those things are
Yeah.
trust that we're using it.
Sure.
Actually buy them in.
Oh, okay.
So you have money, you can buy them in prepaid storage to use them. That will release even more time. Actually, there's a much higher cost. So if you look at that,
Yeah. Okay. No, that is a good one, Lakmal. Thank you.
And Piyush has something to.
I had a few things as well. Karen has explained that there was a big flaw because we didn't include any renal patients at all, and most of the patients with septic can end up with renal failure. So we don't know how long what they're treated with, or if you exclude those, the data is skewed. There will be an increase in costs because of what we compared to Royal and Glenford, for instance, right? We used off like quintuple lines, whereas the Royal use more sort of double and triple lumen lines. So you actually are taking up access to a line, and more lumens you have in the central line, it's going to obviously take up that line access, and you can obviously not. It's going to cost the cost of that device itself is obviously more. So there is a cost implication, and from what I understood from the trial itself, the different hospitals use different rates of intermittent infusion, continuous infusion. Some might have used like a 4-hour infusion, some might use a 1-hour infusion. We don't know which one's which. So somebody may have it might be that the 4-hour infusions might have switched it one way, or the 1-hour infusions might have switched it the other way as well. We don't know where that balance is at the moment in time, because it might be nurse preference as well. Somebody might, if you ask a nurse to give an infusion and we have an injection here, someone might do it over 5 minutes, some might do it over an hour, but they're both considered intermittent infusions. But which one is it? There is a little bit of a skew there as well. So
I think this study they have used it 60 minutes infusion.
is it? It wasn't very
it was
clear on that
mentioned.
one in the first
It was
time.
60 minutes infusions for the intermittent infusions and 24 hours for the
Okay, so it was
continuous infusions.
didn't get to the first time. Okay.
One of the chief investigators was a clinical pharmacist.
Okay.
So what she was telling is, I mean, for an intermittent infusion, it takes about 20 minutes for the nurse to set it up, and then if you have to give it 3-4 times a day, then it takes up 1 hour, 1.5 hours to sort of do it within the day. And if it's a continuous infusion, it takes 120 minutes. So it was nursing time that can be used for patient care if it is continuous infusion.
Possibly. Okay. All right. Good.
Has it changed practice locally or anywhere?
Not yet.
Not we are using for the vancomycin, but not for the beta-lactams.
Vancomycin is a different protocol because that's not quite doesn't fit with the beta-lactams, but that's more of a natural drug which has better evidence. The beta-lactams not yet. I'm a bit on the fence. That one. Cool. Okay.
Thank you.
Okay.